we're going to lose patients in the course of care, and that happens. But we don't have to like emotionally armor up against that. Like, well, it's going to happen. Don't think about it. Don't go, oh, poor me. It's like, no, there's a healthy balance in there.
Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am the production editor, Grace Pratt, and I'm joined by my co-hosts today. We have a great show. We have some faces we haven't seen in a while as people took some time over the summer and we're in and out and doing fun things. But we are excited to be back together today. We have a great show. But first, we're going to start the way we always do with our introductions and our icebreaker question. So, spoiler alert, we're going to be talking about kind of a heavy topic today, and it's something that actually comes up a lot in our residency training program in a group that I do that's kind of our resident support group that meets monthly. And so I thought we might open our podcast in the same way that I open that group every time that we meet with our rose and our bud and our thorn. And if you haven't heard this before, your rose is something good that happened over the last month, something that made you happy or was beautiful. Your thorn is something maybe bad, although like I hate to use that word because what's all good or all bad, but maybe something a little prickly, something painful. It's kind of your low. And your bud is that thing that's coming up that you're looking forward to that has the promise of something ahead. So looking around the circle here for me, and don't forget to introduce yourself too. First, we have Bridget Beachy.
Hello, my name is Bridget. I'm the Director of Behavioral Health at Community Health of Central Washington. We actually did kind of change it, Director of Primary Care Behavioral Health, but I don't know if that's been 100% sanctioned, but I've been putting it on all my stuff. Let's see. Yeah, so rose, thorn, and bud. I would say, let's start with the thorn first. Just kind of being a little bit behind on charts and reviewing of our new trainees. It's been a hot second since I had our doctoral interns. I've had the postdocs for a while, and just the beginning is always, extra challenging. And thank goodness, and if you're watching, I have a fantastic supervisee and incorporates feedback super fast. If anything, it's been me slow to give the feedback, so then he doesn't have time to incorporate it always because I haven't given him the feedback in enough time. So I'm working on that. I'm almost just about caught up, but that's been a little bit of a thorn. The bud is, and I guess this will be a shout out for CFHA and myself and Dave, but we have cohort number 2 of the PCBH implementation lab. It started last Friday. And so I'm really excited. There's 8 sessions. So we have 1 of 8 done. So that's going to be hopefully growing and flourishing if it goes as well as the first cohort went. And I anticipate that it will. And then as far as a rose, it was really cool. I was coming over from our admin building to our mothership clinic at CWFM, and it was at about lunchtime, and sitting in the picnic table was one of our doctoral interns, two of our postdocs. So 1 doctoral intern, 2 postdocs, one of our core BHCs, who's a former postdoc, and one of our 3rd-year medical residents. And it was just the most joyful sight. And I couldn't have imagined 8 years ago, 10 years ago, even 5 years ago, having such a sight of like, these are folks who are all in on the mission, who are contributing every day, and seeing them make those bonds has just been more than my brain could ever even imagine. So I was being a big, like, I guess probably like a proud parent type of deal situation. So I was like taking photos of them because I was going to send in an email just about my gratitude. So it was just a really proud, amazing moment.
I love that. It's so fun to see them connecting and these individual people that you know so well, and to see also them building relationships and leaving the nest and flying away. It's so good. Next, we have Neftali Serrano.
Hi, everybody. Great to be back on the podcast. My name is Neftali Serrano, or Neftali Serrano, whichever way you're able to say it. I'm the CEO here at the Collaborative Family Healthcare Association. And yeah, so rose, bud, thorn. The thorn is always the easiest to come up with, it seems like. So I'll start there. And it's not a bad thing. It's just a life transition thing. I dropped off 2 girls at college this week. So that is just really, it was initially emotionally very hard. Now it's just turned into a little bit more awkward, just a very quiet home. We still have a sophomore in high school boy at home, but it's a different feel. So that's, the bud part of that is related to that. It's like, yeah, we launched a second kid into college, and I know she's going to do awesome. And yeah, so we're looking forward to seeing her do well. And they're both at the University of North Carolina here in Chapel Hill, so they're not far. Yeah. And then rose wise, well, there's lots of good things. There's lots of good things in life, but I'll pick something more sort of personal. I'll go Bridget Beachy route with a sports reference. So one of the ways that I connect with my daughter most is that we're both avid Met fans. And so when I'm watching a game at home, I know she's watching or listening, as long as she's not in class, I assume, to a game on her end. And yesterday to the taping of this podcast, a newer player for the Mets, Jesse Winker, hit a game-winning home run to win the game. And I immediately thought of my daughter, and I was like, yes, we're both celebrating. We're not together, but we're both celebrating. So that was a nice little connecting point. So I'll call that my rose. A Met win and a good father-daughter connecting moment.
Love that. Finding those places of connection, even when we're apart, is just the sweetest. Absolutely. Next, we have Monica Harrison.
Hello, everyone. Monica Harrison, AIM Center clinical trainer practice coach. Whenever Neftali says whichever way you want to say his name, I want to roll my R's and I cannot. I think I need a lesson.
That's why I give people the option, because it's
I want to do it.
if you have not grown up rolling R's, it is very hard to do.
No, and I put in the chat, I wish I knew. Sometimes my tongue will do it. Sometimes I could roll my R. Other times it's like, and I never know until it comes out. So you get what you get. And I'm sorry, the effort and the intention is always there.
Oh man, I might have to try it a couple times before I let you hear it, Neftali, to be like, ooh, no, girl, try again. My rose is I got to this summer cross something off of my bucket list. So I don't have many things left on there, but I got to go to Graceland, and I have wanted to go forever, and finally convinced some people, one I knew well and one not so well, like, hey, don't you want to come do this with me? So I got to cross that off of my bucket list, which was amazing. And then thorn. Sometimes a rose and a thorn can be the same thing, right? So I moved to North Carolina, which is great. But ooh, y'all, moving from another states away was a lot and a very big transition. I think a little bit more than I anticipated. So that was definitely a thorn and still has its remnants as we are trying to get acclimated back to good old hot North Carolina. And then I would say my bud is I am looking forward to somewhat, I was going to say normal, but I'm going to put that in these air quotes, routine. So I have not had my reality TV. I have not had these things that I love. So I am used to school has now started. Let's get housing situated and somewhat of a this is our routine, and I can figure out how to get my reality TV in. So I'll go with those.
And which reality TV are we talking about here, Monica?
Oh man, you name it. Farmer Wants a Wife.
Oh,
Don't
no.
knock it until you watch it. Just saying.
No.
Farmer
I love
Wants.
it so much.
Listen, it's so good. Y'all have to watch it. It is so good. You be anticipating. I think I might need me a farmer. Any farmers out there, give me a call.
Oh,
Listen.
no.
Girl, there's farmers in North Carolina.
I'm just-
I got
there was
farmers.
one
I
on
got
the
cornfields out
show.
my window, Monica. I hook you
See
up
what I'm
today.
See what I'm talking about? I could travel. So don't knock it until you watch it, y'all.
Okay, next month's icebreaker, I'm gonna write it down, is if you were gonna be on a reality show, what show would you be on? So we'll stew on that. Oh my gosh, I love it. Moving is the biggest. It just changes everything, and everything is up in the air, and you literally can't find your things, and it is a pain in the butt. So I'm glad for you that at least the first stage of that, it sounds like, is passed. Next, we have Jen Thomas.
Hi guys, Jen Thomas, Family Med Addiction Med, Morris, Illinois. I'll do all rose bud thorn all in one because it's the juggle. That's my thing. That's the good, the bad, and the growing is figuring out how to do all of the things. The rose, loving getting more involved with you guys with podcasts and CFHA medical director job. It's awesome. The thorn is just figuring it out. My thorn is apparently there's 5 Thursdays in August, so I didn't even know we were podcasting this morning. I was all set for next Thursday, and I'm like, crap, we're talking. So juggling primary care patients and all that this morning, but it's good, and it's so much gratitude to be with all of you guys. So I hope that makes sense.
Absolutely. That's like the August energy, isn't it? Right. Everything is just
Fire hose.
turnover. It is. It's been interesting for me working in, I just had my 10-year anniversary of the residency program. And so I feel like I have 3 new years. I have July 1st is a new year as the residency program starts. We have like August, beginning of school is a new year. And then there's the new year in January when really the lease changes. Like everything is changing all the time. So I hope that those things settle down. And then I'm Grace Pratt. I am the behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma for 10 years now. Had a big anniversary. And my rose is that we kind of looked at our budget and we were eating out way too much. It is the rose because we have been making an effort to cook more at home. And I love to cook. I just have 4 small, picky eating children. And it's real discouraging to make a meal and then no one touch it. Again, there is a rose coming in this, but I decided like, oh, well, I'm going to make it. I'm going to eat it. You can try it. If you don't like it, you can go make something else because there are 7 now and they're big enough that they can make a bowl of cereal or a peanut butter sandwich or whatever. And so this week we've done a really good job of sitting around the table to eat dinner together. And that's what I grew up with. And I really love it. And last night we just sat and we were starting to plan out our Halloween costumes and talking through ideas. And it was just a really, really sweet time. My thorn is transitions being hard in terms of like going back to school and ending camp. And then we all had COVID over about a month ago and it was miserable. So that's it. But my bud is routine. You know, I'm looking forward to hopefully carrying on the streak of eating at home. I'm real good at creating systems, not always good with the follow through and execution. So we'll see how it goes. But I'm looking forward to more of those dinners around the table this year is my hope. Well, I am just so pleased that we're all here. It makes me so happy. Before we get into our main show topic, I do think that we have some news and notes. Neftali?
It is. We are just about 2 months away, actually, almost exactly from the recording of this podcast from our fall conference. So I want to direct everybody to integratedcareconference.com to sign up. And I want to highlight particularly the work that Jen actually has been doing along with her co-medical director, Laura Sidari. If you don't get a chance to meet Jen and Laura, you will have missed out. These are 2 just amazing people and amazing professionals, amazing medical providers who are really spearheading our efforts to include and to create a community around medical providers within our larger CFHA community. For those of you who might be newer to CFHA, we really position ourselves as the association for the care team, for the modern care team, right? The team that's really a team. And, the medical providers are a really big part of that. So we can't do integrated care literally without them. So we've got a lot of awesome content that Jen and Laura have curated, sort of kind of like a medical provider track, so to speak. And, you don't have to go to the conference and just go to those sessions, but it's an easy way to find those sessions. And when they listed it out, just I think it was like a week or a week and a half ago, they said, Jen posted it and it's like, hey, we've got some great stuff happening. It was like fantastic stuff about leadership, stuff about, nuts and bolts of integrated care models, stuff in particular areas like addictions, just things that you're going to walk away with feeling like as a medical provider, hey, I'm better off as a medical provider, and I'm better off as a teammate as a medical provider having come. And then Jen and Laura also put together these special half-hour time slots during the conference that are just going to be more for like connecting. and for people to really form communities so that you don't just come and, hear a bunch of sessions and speakers, but you're connecting with other people meaningfully. So I'm really excited about that. And obviously we've got great stuff for all the members of the care team at the conference. So again, integratedcareconference.com. And then the other thing that I want to point people to is, if you haven't visited our website, you will notice that it is brand spanking new. And along with it, a little better organization of stuff, especially resources. So I want to encourage you to visit our website, cfha.net. And there you're going to see a resource tab in the main menu. And there's a resource library there that we're going to be building out over the next few years. So go visit the resource tab. The other thing that's really nicely organized now are all of the events, including the event that Bridget talked to you about. Bridget and Dave are talking, the PCBH Lab. There's so many talented people that are contributing to training events that are really, really meaningful to behavioral health professionals, to medical professionals, to care managers. So check it out. Check out that part of the website as well, and give us some feedback. If you like the website, if something could be better, we're always willing to get feedback. So there's much more that's going to be coming your way. So I'm excited about the fall. That's the other bud I should have talked about. The fall, we've got a lot of really cool stuff coming up. For now, we're going to leave you with that. But stay tuned, because this is going to be a really exciting fall for CFHA.
I love that. Thank you. The only other news that I have to add is that our coming of age series is still in production. There are 2 episodes currently in your main podcast feed. There's another one in my editing app that's almost done and hopefully will be out this week. And then Deepu and I have several others in the pipeline. So the goal is to get all of this out by the conference as the lead up to our big anniversary year. And so I hope that you are able to listen to those. The feedback we've gotten on them so far has been fantastic, and they've been so fun to do. So there are more of those coming through to look out for.
Yeah, these are just to plug that a little bit more. I listened to, oh boy, I'm forgetting their names, Mac Beard, and who's the other one who's talking with him?
Bill Doherty.
Bill Doherty. Oh my goodness, what a amazing conversation between a mental health professional and a medical provider from a perspective of 20, 30 years ago.
Yes, one of my favorite things about this series, I mean, we're capturing the history for sure of the organization, and then right alongside it, you can hear as integrated care grows up. But then the format that we're using is having 2 people who know each other and have a relationship and have a history share this reminiscing together and sharing their ideas. And there's even, like, as you'll listen to one episode, someone will talk about something, and then from another episode down the way, you'll hear it from a different perspective from someone else who was there. And so it's really this very cool convergence of all of these different threads of the story that make up the tapestry of our organization. So it's just, I just couldn't be prouder of it. Yeah, I can't wait for it. I really need to get more of them into the feed so they can be in everyone's ears and everyone can enjoy it as much as I am. So that's the goal, to have them out. Well, I want to move us into our main show topic because I know that we're going to have a lot to say. This actually was prompted by, I was chatting with some friends of mine and asking them, what's been going on lately in your integrated care lives? And one of my friends, who has about the same history as me, so she's been in the field for close to maybe 12 years or so. And she said, I had a patient die and it really shook me. Can we talk about that? It was sad and I'm sad about it. And so I asked her for a little bit more details and also asked her permission to share this. And she said, absolutely. So she's seen this patient just one time in integrated care. He was new to their clinic, and he was a kind of he was a 45-year-old man who had a lot of significant health comorbidities, and he was also unhoused, and he knew, and their conversation was pretty frank about the fact that he really needed some round-the-clock care. He needed some more intense level of healthcare, and if he didn't get it, he was going to die. And she had, like, his mom was on the phone during the encounter and was tearful because she wanted to help him, but wasn't able to help him transfer out of his wheelchair, and just wasn't able, because of her own health issues, to help him. And my friend, who was the behavioral health provider, helped write a letter to try to advocate for this patient, to help him get a level of care that he needed. And about 2 weeks later, she got a notification in the EMR from the psychiatrist about something. She was like, "What does this mean?" And she went to look in the chart, and there was just a pop-up message saying, "This patient is deceased." And she was just talking about, and what I wanted to open to us, I think that story encapsulates so much about this hard part of our job of working with people that are sick and are sometimes dying, and the bad outcomes of that, and that there's so much about this that especially feels preventable to us. But just how are we grappling with that? How are we making sense of that? And I think that there are, this conversation, I hope that we can also talk about compassion fatigue and disenfranchised grief and all of these pieces. But as I tell that story that my friend recently experienced, what resonates for you, or what do you see in your own work that reminds you of?
Well, I'll jump in.
Yeah, go ahead.
It's obviously a lot of it depends on the particulars of the situation, right? How it happens and how it affects the team. Sometimes it's just a little bit easier to sort of assimilate, because we might have, like, I walked with a patient for probably a little bit more than a year as they were dying. And in fact, this was a very unique situation, because I think I only met this person in person once. The rest of the time it was by phone, because the person lived pretty far away from our clinic. I was the only Spanish speaking provider that could talk to the person. So, and I probably had maybe monthly to every 6 week type visits in episodes, as this person was dealing with various very serious health issues, including cognitive decline. And so in a way, again, the expected nature of that helped me and helped the provider kind of cope with that loss, because we kind of knew it was coming, and we grieved it sort of along the way. And I think what makes the difference for integrated care teams is that we were able to do that together, right? It wasn't us doing that individually. And in the end, we were able to share gratitude towards one another. I told the physician, I was like, you made such a difference in their lives. This family loved you and loved the way you cared for their dad, their husband. And he was able to express similar things to me. And that helped us grieve that, because we knew that we carried it together. And in that case, also, the family was also extremely appreciative. And in fact, this was a Mexican family. His wife, who again I think I may have met once, I'm not even sure, but we talked many times over the phone, and she brought back a beautiful mug that I still have, a beautiful mug set with a little dish and coffee from Mexico, and was just effusive in her appreciation for what the role that I had played in her husband's life as he worked his way to death. So that kind of situation it gives it a different context. It allows you to grieve. It allows you to work as a team through this in a way that's actually, in a way, it's honoring and it's healthy and it feels good. But it's not always like that. Sometimes the circumstances are such where, like what you're describing, that's a lot more hurtful because of the conditions in which that individual lived the last few days of their life, and the sort of social decay and lack of support that the person had, that hurts us. And in those situations, again, sort of the same thing, but we have to deal with it as a team. We have to make sure that we're not taking it home ourselves individually. And I will often try to initiate conversations with my physician colleagues around it, because they're not usually as primed necessarily to ask about those things. But I'll just make a mention. I'll say, hey, this really sucks, doesn't it? I mean, this hurts to see this person this way, or something like that, just to open up the conversation.
I think there's a little bit of a paradox in my experience about, I love that you're talking about, the different roles of the people on the team and how being in a team does allow us, I think, to grieve a little bit more because it's a disenfranchised kind of grief. And when I say that is like, we're not the person who experienced the loss. We're not part of the family, but then we still have feelings about this. And in some ways, I think physicians are more primed to expect to lose patients. The nature of your training, the volume of patients that you see, especially when we're working with primary care and you have all ages, you have all this, you're ready to lose people. It's more an expected part of the job versus for behavioral health providers, especially if you come from a traditional training background, you're typically, again, because of the volume of your caseload and because of the work that most traditional mental health therapists do, it's a much less frequent occurrence, much more rare to have a patient die. At the same time, I think we as people who have been trained in the mental health field are encouraged through supervision, through our training, through our education to think about transference and countertransference and talking about how cases impact us in a way that physicians often are not. And so in some ways, the physicians are like, yeah, people die and it's really sad. But I've experienced that before. Versus in other ways, therapists are like, okay, we need to be able to talk about this. And so it can be a blessing and a curse because it can mean that we both have strengths to bring to the table. We can normalize, we can open the conversation, we can experience the grief aloud as a team, or it can mean that we come from really different perspectives and we're like, no, I'm not going to talk about this. We're going to get over it. It's part of the job. We're going to move on. Or like, you're a therapist, you're not my therapist. Like, there's different ways that it can go, I think, depending on the makeup of the team. What's your thoughts on that, Jen, coming from the physician's perspective?
Oh, so many thoughts. And it's so weird that you bring this up I didn't know this was our topic for today, but I literally had this conversation with my primary care team 2 days ago, Tuesday. We sat outside for lunch. We had a patient pass away 2 weeks ago, and it was really difficult for the team. And we were sharing that on the clinic side, because we work for a hospital system, on the hospital side, ER staff, they might have a better process for debriefing, right? Like someone comes in and dies tragically. You hear that that's their culture of, hey, let's sit and talk about that. We were commenting in a frustrated and kind of, what about us kind of way of like, we don't have that process in the outpatient space. And yeah, we weren't related to our patient that died, but that stuff's traumatic and we don't hold time and space to talk through that. So I think I was literally going to actually ask you guys about like, do you have a process for that for clinic? I mean, it's so weird that this is what we're talking about because we need that. We all sat around that table looking at each other like, we need to be talking about this. It doesn't mean it defines us and we don't have to be like in mourning for her loss, but like there should be something. We should have a framework. We're just lacking something. And I think that's why I've always just been drawn to you guys in integrated care is that your training, your background, your personalities, all of that have just been so helpful to, I think, the medical folks like, oh, maybe we can do some of that. And it doesn't have to be all we do. We still can have yes, we're going to lose patients in the course of care and that, yeah, that happens, but we don't have to like emotionally armor up against that. Like, well, it's going to happen. Don't think about it. Don't go, oh, poor me. It's like, no, there's a healthy balance in there. I don't know what that is. I would love to learn from you guys on how to do that. So yeah, do you guys have any tips or experience with like primary care teams when loss happens? Like, are you debriefing? What do you do for your caring for the care team? I'd love to know, honestly.
Yeah, I think it varies depending on the setting. I do not think it's the norm that people think about it and automatically do it. When Grace first asked the question, it was this long pause from all of us. My memories were flooding of like, oh, all the different environments that I've been in terms of integrated care teams and how differently everyone has handled it. Also depending on so like Neftali was talking about how the death has happened. I will say for me individually, deaths that have been related to mental health in patients that I have seen definitely hit me harder. Like if I just saw them yesterday or, that has happened. I would say for me, specialty medical team I was on when I worked in nephrology handled it the best because there was a process. We had patients who actually passed away a lot that had been on dialysis. And so they actually had a process and step for conversation routinely about how our patients were doing. So we had a morning huddle and an end of day huddle. And it was usually during those huddles, if someone had passed away, that we were following a stepped process for sharing and conversation about that. The one thing I will say, though, before we go down kind of that rabbit hole of how we don't have a lot, is of all the teams I've been on, the ones that were teams, even if we didn't have a process, was much better than being in private practice and losing patients. And then who do you then talk to that might even know this patient, right? Like there's no connection. It feels very different talking with peers about a private practice patient that I lost who had no connection, and colleagues on a team that at least knew, like, oh yeah, he used to come in with his wife, right? Like there was some connection there. It felt very different for me as an individual. So I will say, even if there's not a process, there is a joy in being part of a team that's going through and experiencing that together.
Yeah, I couldn't echo that more. Everything that you all said. And I feel like we may have talked about this at some point, but yeah, we don't have necessarily a process, but I shouldn't be so shocked about how comforting it is just acknowledging it with like the nurse or the physician, just seeing like, Monica, almost the way you just described it, where it comes through that a patient died, right? And you're in the pod, there's a nurse, the MA, the physician, and you're kind of maybe finding it out in real time. Like in the middle of clinic, you're finding it out in real time and just seeing like, oh, my heart. Oh, I mean, we kind of maybe saw it coming, maybe didn't, depending on the context or the situation, but just seeing that they're feeling it allows me to be okay with feeling it. And I do feel like we don't take like a long time, and we probably should have a debriefing process or something, but there's just this like really sacred moment that's held where we're just all like, and you feel that twinge, you feel that pain. And we normally say something nice about them. Oh, they were so kind, or they really fought hard, or even some of our more ornery patients are like, yeah, they had a personality, and so we have that moment, and I think it's really special. Yeah, it's just a really special moment.
Part of what's, go ahead.
No, you go ahead. Good.
I was just saying, part of what's so hard about the grieving in this role is that the role is ambiguous in terms of what is our place for grief. And there's a really great analogy about the ring theory of support. I don't know if you guys are familiar with that. The idea is that when something traumatic happens, imagine like a target with rings going out, or like, ecological theory for us, like theory nerds. And in the center is the person who it happened to. And then the next ring after that is their immediate close friends and family. And the next ring after that is like their close community, their neighbors. The next ring after, and their extended family. And the next ring after that. And so you go out in these rings, and the idea of the ring theory of support is that when that tragedy happens, you should be lending support towards the inner rings of the circle and receiving support from outside. So like if someone's mother dies, you don't go to the person whose mother died for support for grieving their mother because they're further in the ring, right? And I think this is part of the challenge, is that we're kind of far out of the rings. There's some distance between us and the person who died, but that doesn't mean we don't have feelings. And so finding those people who are in that ring with us, or even further out, whether that's a close colleague who knows you from training that you can call up and say, I know you don't know this person, but I have just got to tell you this story. Because when we're grieving, that's what we need. We need stories, we need connection, we need to name the feelings that we have. And that's ritual. Ritual is anything that is something that you do with purpose. And so whether it's taking that moment, if you're not watching on YouTube, Bridget put her hands over her heart, just feeling that grief of that patient. And whether that's something that you literally do in the pod or not, even that is ritual, right? Connecting and sharing a story and naming this together. And so when we're grieving, that's what we need. We need ritual in our ring. We need to offer support inward where we can. And I know some providers find it really meaningful to go to the funeral of patients who have died and show that support. A good colleague of mine, who's our program director, has seen a lot of his patients and their families for 25, 30 years. And he really tries to make the point to go to the funerals of his patients who have died. And the families always receive that support really well. And obviously, that's going to be very context specific, very dependent on the person in the situation. But we look for ways to offer support, reaching in. We look for ways to receive support, reaching out. We have to find our place in those rings and think about what that might look like.
Yeah, and I think that's why my mind always goes for things like this to just team. So, your question, Jen, is really interesting about like a process, and I'm not against like having a basic framework. I think like in the ED, you mentioned the ED. My wife, as you know, is an ED physician, and they don't actually always do a great job at this. I think they often do not, but she takes special steps to make sure that when a patient dies in the ED, that they, sort of go into the room, the team that attended the patient, go into the room and have a moment together, silence. They can share real quickly what they're feeling and honor the patient, and then, and then try to move on with the rest of their shift, right? So you can have sort of basic frameworks like that can help, and they're usually not very complicated, right? So if you're trying to do this with your team out there, it's really just giving people space to share their feelings and honor the loss, and really just to hear each other out in a safe space. And it doesn't even need to take very long oftentimes. But in truth, Jen, what I thought of when you said that was, the answer to everything is basically team. The teams that do this well are because they are teams before any of this happened, any of the crisis happened, any of the hard times happened. So, even what Monica said about, her teams that seemed to do it pretty well, and they huddled a lot, right? They huddled in the morning, they huddled in the evening. They were just practicing really good team behaviors. And teams are really just mini communities. That's all they are. They're mini communities. And if you have a mini community that is a well-functioning community, meaning they know each other's roles, they communicate well, they support one another, they have each other's back, then when something like this happens, they are their own sort of ring around each other that provides that support. And that's what I've experienced in these sorts of situations. When I'm in a clinic that the team is really just a good team, it honestly almost happens organically that, someone steps up and says, hey, this was really hard. What are you feeling about this? I'm feeling this. And then that support sort of happens, as Bridget said, in the pod. It's like you didn't have to organize a meeting for it. It just sort of happened in the pod, and people just said, yeah, let's take some time to help each other around this loss. So all that investment, all that's for me to say, invest in your teams proactively, because it's so important for not just like this form of loss, but I think healthcare actually involves lots of losses. We've talked before about burnout and all the paper cuts that you get. Those are all like mini losses. And there's a lot of those in healthcare every day. So really good teams have to be organized in such a way that help us deal with those paper cuts, those little mini losses all the time. So yeah, I would say don't overcomplicate like a process around grief, but invest in your team, and you're going to have a team that probably is going to be able to manage grief and loss pretty decently.
I wonder, if there are things or characteristics that seem to make this harder, or even like the unexpected things that we could think about what might make it easier for teams. So, when I said that my friend was notified by just the pop-up message in Epic when she opened the patient's chart, are there any things like that you guys have experienced, or things that you think that maybe team leaders or systems could think about to try to ease the process?
I could be getting a little bit obtuse with your question here, so I apologize in advance. But I guess maybe to piggyback on Neftali, I think that one of the best things we can do if we are so in that position is be a good leader for our teams and encourage them to be clear processes of leadership on the medical level, because if people are having that psychological safety and that employee engagement, which comes from mostly that core relationship that you have with your supervisor, and making sure you're having frequent one-on-ones, making sure that you're always having annual evaluations, making sure that they see, celebrate, and expect of you. If you're doing those things as a leader, it's going to produce high psychological safety at work, then that's going to produce employee engagement, which then I think is going to be the kindling for what Neftali described of that kind of spontaneous situation. So I think that maybe that could be the best way, is just investing in leadership if you're in that role, or asking for better leadership. I mean, that could be a situation. But if folks feel like they couldn't go to their supervisor, or they wouldn't go to their supervisor, or they're feeling psychologically unsafe at baseline at work, then they need to probably talk to their one up, or if they've tried that multiple times, their one up, or some route in HR to try to start advocating for what they need.
Yeah, there are definitely harder situations that will challenge that team cohesion and psychological safety. Things like, a good example I think is going to be, and we actually dealt with something like this recently in clinic, a suicidal patient, or a patient that has successfully committed suicide. That can be extremely hurtful for lots of really complex reasons, right? For the caregivers, the care team. And if there's not pre-existing psychological safety, you can imagine how it would be hard, right? Let's say you're the resident, or you're the physician, and you want to process this, but you feel like you might get blamed, right? Or you feel like your process of working with the patient might be analyzed in a, pejorative way. So that kind of situation is definitely going to challenge that. So that's why that psychological safety piece is such an important precursor to just doing any work on grief and loss. But if you do have strong relationships, and you have a culture where it is okay to have feelings, and it is okay to express those feelings, and it is okay to be a human being. That's sort of the part that I often see somewhat missing in medical settings, right? You're not okay. It's not okay to make mistakes. It's not okay to not know all the answers. So if you have that culture, then you can deal with even those really, really hard, complicated, loss situations. Not perfectly, because how do you assimilate some of these situations? I mean, I don't know how your resident dealt with, the lack of housing this person had, and the lack of support. I mean, that's a hard thing to kind of swallow, right? It's hard to assimilate, and loss is just hard. But if at least you have that safety in your team, you at least know you're not alone. You at least had an opportunity to express those feelings. And in the way that only humans do, you over time make sense of what doesn't make any sense.
I'm hoping we put the recommendation. So I don't know if people ever get to see our chat, right? And maybe I should have asked that before. We be chatting all in it sometimes. But one of the questions that Jen asked that I thought was a good question that Neftali is almost answering is, how do you create that psychological safety at work? Because it's one thing to say you have an open door, but if nobody wants to walk through it, who the heck cares that you got an open door? Like, so what? But promoting that open dialogue, like Neftali is talking about, right? Where you're creating this welcoming environment as an organization, as a leader, that then is going to reinforce psychological safety for people to share things with you. So welcoming diversity in people's thoughts and what they share and all of those things. And I could see people going, okay, well, where do you go to get that started? And Bridget gave a recommendation for structure and format. And again, it's not an end all to all, but sometimes people want to know, like, well, where do you start? Like, where do I even start? So I don't know if we could put that in notes somewhere or not, since people probably hopefully don't get to see our chat.
People don't see our chat. And
Okay, great.
But again, add the links that, we're sharing into the show notes. I think the consequences of what we're talking about is so important, in terms of, this is about yes, the grief and mental health and experience of our caregivers, but also secondary traumatic stress and compassion fatigue and moral injury and all of these pieces that are so central to workforce retention and having a group of providers who are able and willing to do this work. And sometimes I think, for better or worse, when we're talking about going to leadership, when we're talking about trying to get things done, tying it to those numbers does make a big difference. If we can point to, like, this is beyond burnout. This is not like when compassion fatigue sets in, when secondary traumatic stress sets in, this is not you need a vacation. You need to get to start using AI in your EMR so you have a lower documentation burden, which is a whole other conversation, whatever. This is not a simple solution. This is a traumatic response. It's a trauma response. And that's also part of, I think for leaders who are listening, who are wondering what they can do at a system level, having your system, having your clinic, your system, your whatever position you're in, become a more trauma-informed organization is also a really important part of this, because trauma-informed care, which we have done a show about in the past, is not just about the delivery of the work that we're doing directly in our patient care, but it's also in how we respond as an organization, how we understand the trauma impacts even the people that are working with us, even our employees. And so that would be a piece too, in terms of, what can we do as an organization to be more trauma informed and to name and recognize this. Bridget, you were dropping all kinds of nuggets in the chat. I wonder if you can highlight a few of them so people will know, what to look for.
Yeah, I think the one that you often will hear me talk about is Quint Studer's work. And so he runs something I think called Studer Group or Studer Consulting, but his full name is Quint Studer. And if you just literally Google Busy Leaders Guide to the Busy Leaders Handbook, How to Lead People in Places That Thrive by Quint Studer, that will come up. Radical Candor by Kim Scott is another really good one. Anything by Brene Brown, because she talks a lot about using your own vulnerability and making kind of like relational leadership and ways of increasing trust, I think is another thing that she does really well. And then Dave and I have a saying or a framework, a really easy framework. I'm always looking for the easiest framework. I feel like if something has more than 3 things to remember, it's like in primary care, it ain't never going to be remembered. So our framework to leadership is see them, celebrate them, and expect them for the folks who report to you. So if you're, seeing their context, understanding their context, celebrating them as kind of, as Monica was saying, what they bring to the table, as well as their contributions at work, and then having clear expectations of what success looks like, it's a pretty good recipe for having close connections, high psychological safety. And then again, as the whole group has already pointed out, when you have those ingredients at play, people are able to take things and run with them and have it grow a lot easier than an environment where you have a really good framework, but folks are, burned out, for lack of a better word.
Yeah, and I'm actually curious, Jen, what you did with your team, because I know your leadership and I know how much you pour into your team. What did you guys end up doing?
Yeah, we did what you talked about, what came natural. We just kind of sat around the lunch table and talked about it. And how do you feel? And this was, upsetting, and processed it as a team as we should have. It was just kind of, yeah, I think you're right. It doesn't have to be a framework. It was just, I guess, holding time and space for it. I think in primary care, you're so busy and you have all this pressure to be productive, and we don't have time to huddle. We got 3 patients waiting, and it's like, we got to pause that thinking and go, like, we do have time. We make time. It's what keeps us sane and here, so we don't quit and burn out. Like that, I think, is where we got to go with some of that. And so we did. So yes, I think we're more right on than I even realized. So thank you for making it seem that simple of just do the human thing, talk to your teammates. And we have an amazing team. And that's what primary care is, right? The people you're in the trenches with day in, day out, and it makes all the difference.
Oh
I like
gosh, I
that.
don't.
Do the human thing. I could just
Yeah,
I like
see
that too. It's a
Right?
tagline. I like it.
I don't know that there's a better note to end on. Don't underestimate that power of connection, that power of relationship, and the work that you're doing is so important. Do the human thing, connect with your people, be a person sitting in front of another person, and that's the biggest thing we can do. Oh, this has been so wonderful. I'm so happy to see all your faces again. I'm looking forward to our conversation next month already. And then before we know it, we'll be in San Antonio. So I hope that you all take care. And thank you to my co-hosts. Thank you to our listeners for joining us. We'll talk to you again next month.